Next slide. Just as a reminder, this call is being recorded. At this time, I'd like for Kelly to hand it over to Kelly Parker for everyone, again, to mute your lines with the exception of Kelly Parker. Thank you so much for joining us today to provide us with an update from the Virginia Hospital and Healthcare Association. Kelly, have you joined us? Okay, next slide. Again, this is a reminder, if you are not connected with your Virginia Regional Healthcare Coalition, especially regarding PPE, please make sure that you are connected with those. Next slide. Next slide. All of the contact information that you need for your healthcare coalition is listed here. At this time, I'd like to hand it over to John Burns, who's going to provide us with some information regarding his experience with the COVID-19 virus. Melissa and John?
I say, actually, Dana, you're handing it over to me to ask John some questions. So thank you for that. Good morning, everyone. John, thank you for taking the time in what I know is just an incredible, unprecedented period of time for everybody, but especially with what you've had going on at Westminster Canterbury Richmond. Could you take us back to what probably seems like a lifetime ago and share when did you first mobilize and why before you even knew you had a case on campus?
Sure. Thank you. Thanks, Melissa. Thanks, LeadingAge, for letting us, giving us the opportunity. So yeah, we created a coronavirus task force on February 26th as part of just a sort of a standing operational meeting. We said it's time to begin to dust off our pandemic response plan, make sure we are prepared if and when, and we were running under the assumption it was going to come to the East Coast. It had already come to New York, and it was going to come to Virginia. So we stood up a task force on the 26th, and at the same time, we created our coronavirus or COVID-19 incident command structure, which is a little different than your, if you have a hurricane or whatever. So we established that structure in the last week of February. And then in the first week of March, we flushed out what were the areas of, well, we established our corporate philosophy towards this response plan, and then we figured, as a team, we determined what our key focus areas of preparation were going to be, and we were ready by the 3rd of March, which is really when we kicked off our incident command, pre-incident command meeting, knowing we were headed in that direction. So I guess that's the answer to your question.
And so, John, just tell us about how did you come to find that was this resident exhibiting symptoms? How did the testing happen? If you could share that piece of it for us.
Sure. So well, let me just back up a little bit. So on the 3rd, we sort of initiated our response plan on the 3rd. On the 4th of March, we implemented a travel log where we documented where all of our residents were and what travel they had on the books and where our staff were. And we made a concerted effort on the 4th to determine where folks were. And so that for us was really a key moment when we realized we had a number of residents in Europe, a number of residents in other states where coronavirus had already become a community spread COVID-19 situation. And so the resident and his wife returned to Westminster Canterbury on March 9th from an extended stay in Florida, which is their home of residence. They moved to our campus in December from Florida, moved in, and then moved back to Florida to get their situation down there settled and moved back. So they came back on March 9th, which is Monday of 2 weeks ago. And then if you've been following our story at all, you know that night they went to our Sarah Bell November Theater to see the Capitol steps. So we had 290 people in the room with him that night, which is sort of another big moment later on for us. But so on the 9th, on the 11th, we had our first case in Central Virginia, which was the Hanover County case, which to us was the trigger to implement our incident command and lock the campus down and close our nursing home and assisted living and take it to the next level. And so that started on the 11th. On Friday of that week, which I think was the 15th maybe or 14th, the resident was getting confused, increasingly confused. Can someone, whoever's got their mute off, can you mute your phone? There's a lot of feedback. But anyway, on the Friday of that week, he fell in his independent living apartment, and we admitted him to our Parsons nursing home. Can I just ask everybody mute their phones? We're getting a lot of feedback. Thank you. So on Friday, he went to the nursing home. Saturday, his mental status deteriorated greatly. On Sunday, it got to the point where he was really like maximum assist of 2. He never had a cough. He never had shortness of breath. He never had a fever while he was with us. But on Sunday, Will Blackwell, our VP of Health Services, we were all here for the incident command meeting, and afterward, he and I went to Parsons. He then was involved, and he sent this patient out because of his deteriorating status. I think as a routine practice at VCU Health, they tested him, and we then learned Monday night, the following night, that he had tested positive in the hospital. And so I got that word about 9:30 at night, and we then went into, excuse my French, but everybody did a very loud oh shit, and then we said, what do we do from here? And everybody came in, and we got, we communicated to everybody by midnight that they were to stay in their units and not come out, and that we'd be on TV, our in-house TV at 9 o'clock to tell them more about it. But we told them that night at midnight, we have a positive case and you need to stay in your apartment. But we learned it from the Virginia Department of Health, who heard it from VCU. As soon as they had a positive case, Dr. Avila, who's the director of public health for Richmond and Henrico, his staff called my infection control preventionist, and that mobilized.
So John, I know you've done a ton with communications with everybody, the media, families, residents, all your stakeholders. What advice would you give to the other members on the call around communications?
Well, so I've thought a lot about this over the last few days. First thing, as a CEO, and there's a lot of CEOs on the call, or VPs of health services or whatever. The first call I made was the smartest call I made, which I called my chairman of the board, and I told him. And the reason is because I knew everyone on my team was going to be doing the same thing I was doing, which was thinking about 10 million operational, oh crap things we got to do. And the chairman of our board, he's a very thoughtful guy. He's far smarter than I am. And I knew he would be able to disconnect from all that and think. And I wasn't going to be able to think for a little while or a couple days. And I asked him to just be a sounding board and to think and jot down his thoughts and advice and counsel. And so I had him calling me every couple hours for the first 2 days saying, have you thought about this? What about that? It was really helpful to have an advisor behind me who is a trusted ally, but isn't wrapped up in the in the, what are the whole day-to-day thing. That was really helpful. The other thing, and we're Westminster, Canterbury, Richmond, and CCRCs in general are just really blessed to have resources. But what we did, and it was part of our incident command structure, is we designated a communications chief who has a team, and we asked that they stay home and they work from home and they stay focused 100% on writing copy, pushing copy to every single channel that we'd already articulated what those were. We keep it fresh and we be transparent. We share every single piece of communication with everybody so that everybody knows, good or bad, whichever way the thing went, we were gonna put the whole story out there. So we didn't have to, and we directed our board members and our residents' families and everyone to those channels. So we didn't have to recreate a million messages for a million different stakeholder groups. And it's really worked. I mean, it has really, really worked. And we've gotten a lot of really positive support from a broad community because we've just shared everything with everyone and told the same story over to everyone.
That's great, John. Thank you. I know that we have to move the agenda along, but I want to thank you for your transparency and willingness to share. If you all have questions for John, just put them in the chat box, and I can ask him after
Has
our
she
other
been through
presenters.
the training? Does she have?
Melissa,
been
can I
in
say
contact
one
with
more thing?
anybody that
Sure, if somebody could mute their
is the
phones.
COVID markers?
No, it was just she's been around somebody with flu-like
Somebody's
symptoms.
talking about patient stuff on the phone. Listen, one last comment, which is a call I made first thing Tuesday morning on my way to work, was I called Melissa. And she was, she then came and participated. And having partners, 140 or however many we have, in standing together is really important. I feel for those communities that don't have partners and don't have friends and don't have support. And there's a bunch of them out there. But as a LeadingAge community, we've certainly felt that support, and Melissa and the team. So if God forbid this happens in your community, make sure you reach out to LeadingAge Virginia and national and make sure, because they're fabulous partners who can help and be sounding boards for questions, and I've shared a lot of silly, ridiculous things that we've learned along the road here with Melissa, because the first time any of us have been through this. So thank you all for your time and attention.
John, can you stay on, because questions are coming in for you, so I'd like to circle back. I know we have Tara
Sure.
Ragland next, who's got a tight time frame, so I'm going to hand it back to Dana. Thank you.
Thank you, John. I'd like to ask if Tara Ragland could please join us. If we are going a little bit out of order from our presentation today, but she has a call that she needs to get on. So if Tara, did you have anything that you'd like to share with us?
Can you hear me?
Yes.
Okay. I'll just take any specific questions that anybody may have at this time for us. I'm not sure we have a whole lot of additional information to add other than what we talked about, I think, the last time we were together, but I'll definitely take any questions or concerns anybody has at the moment.
If you could unmute your lines if you have a question or comment for Tara. Okay, well, thank you. Thank you, Tara, for being on.
Well, I want to thank everybody for all their hard work. I know these are, as we keep saying, unprecedented times, so I'll just like to take this time to thank everybody. But please don't hesitate to reach out if you have questions for us.
Thank you so much. We really do appreciate that support. At this time, I'd like to invite Kelly Parker with the Virginia Hospital and Healthcare Association.
Hey, good morning. Can you hear me?
Yes.
Awesome.
Thank
Good
you,
morning,
Kelly.
all. Yeah, thanks for having me on. Just kind of give you a bit of a situational update from what we're seeing at the state and what we're trying to work through. Obviously, the case counts continue to rise, nearly 300 confirmed cases in the state right now, as reported through LeadingAge. I will say that there are a lot of pending cases out there, as you all are probably experiencing in some of your facilities, as well as our acute care hospitals. They're experiencing the same challenges on testing and getting prioritization of testing and just the availability of testing for rule-outs. The big challenge right now that we are still just drastically trying to work through is the shortage of supplies. We've been working with our healthcare coalitions, through our healthcare coalitions, to get the distribution of S&S supplies to them so that they can get that out to you. I will say that the S&S supplies shipment that we received is it's almost laughable. It's so small. So we are providing support where we can, but we don't have nearly the amount of supplies that are needed for this response right now. So we ask that you still continue to track what your needs are, work with your healthcare coalition as supplies become available. We're revising our distribution plans and allocation formulas to try to figure out the best way to get that out to not only your facilities, but also our acute care facilities and dialysis and some of our behavioral health hospitals, as there's a lot of people that are in need of this right now. Most of our coalitions don't have any PPE left. As I mentioned, the supplies that they were given were very, very limited. We are working with the state right now to try to find vendors to procure PPE. We've provided them rough numbers in terms of the amounts that we would need, which we know we won't get, but we're trying to find any avenue we can to purchase supplies, and we'll keep you all informed once that is available. The only thing I can continue to harp is just work with your vendors, just continue to push them, utilize some of the CDC guidance on PPE utilization, which I know is not our best option right now, but unfortunately it's the times that we're working in. Other thing we're looking at from a state perspective, and this is more for the acute care setting, is alternate care sites. Some of the modeling that we're looking at shows that this is going to be a long response and a long pandemic, and the modeling that we're showing is not great. It's not favorable in terms of the amount of patients and the amount of resources that we're going to need to care for. And so we're working with the feds on alternate care sites and trying to determine exactly where those need to go. Obviously, the priorities right now are Northern Virginia, Eastern Virginia, and Central Virginia. But as the disease spreads or the virus spreads, it'll continue to have a need for these type of facilities all over. But they're seeing what's going on in Washington and Italy and New York and trying to anticipate that we will eventually be feeling the same type of needs. So working on that, obviously staff and stuff for alternate care sites is going to be a massive challenge. Trying to work through any angle that we can to get those off and to alleviate any burden we have on our existing health system, but not sure entirely how that's going to play out yet. I think that's really all I have, unless there are specific questions.
Thank you, Kelly. Are there any questions in the chat for Kelly?
Kelly, what does quote unquote long mean from your point of view?
That's really, it's unknown at this time. The big factor here is social distancing. So we're working with a lot of different models, and we're working with the state with a lot of different models. So UPenn, Harvard, Johns Hopkins, a lot of major universities have come out with these models in which we're trying to predict how long, this transition or this trajectory of virus will take. We've seen projections that.
What's your question?
We've seen projections where this could, depending on the percent of social distancing,
What are my
could
choices?
last anywhere from.
Yugoslavian would be better.
I'm sorry, somebody's not on mute that's talking about Yugoslavian stuff. We've seen projections in terms of our peak anywhere from May to September. So, I mean, this could really be a 3-4 month endeavor. It could be 6, 12, 18-month endeavor. There's no way to predict that right now. The only factor that we know has impacted the flow of the spread of virus is the percent of social distancing. And the only countries that have been able to completely stop the spread of this virus are the ones that have gone on total lockdown. So there's a lot of unknowns there. Obviously, there's a lot of models that give you different variations. It depends on the decisions that are being made at the government right now in terms of social distancing and lockdown, and all of that plays a factor.
One more follow-up. What guidance are you giving your hospitals then in terms of the modeling and what to prepare for?
So we haven't really given any of them guidance yet. As I mentioned, we're working through a bunch of different models to try to figure out what the best guidance is going to be for Virginia. So the only thing we're saying right now is that this is going to be a long response. And just to prepare for that, obviously, we're working with, right now, I mean, short-term needs is fixing the supply chain. So there's a lot of manufacturing industries that the state is working with that we're providing information from textile manufacturing companies, et cetera, who are almost like we saw in World War II, stopping production of what they typically produce and starting production of medical grade supplies. And so there's a lot of that discussion where what we're trying to do right now is try to fix the immediate needs of supplies while trying to slow the spread and eventually stop the spread. Once we have better outlooks and we compare all of our models and get our heads together, which will hopefully be next week, we'll probably have a better understanding of where we stand and maybe what direction the government's going to take, and we'll be able to provide better guidance. Personally, I am preaching social distancing to everybody that I know, and telling everybody to stay home. I mean, it's really hard for the public to understand the severity of something they can't see, especially if it hasn't affected them directly or impacted their exact community yet. So I'm trying to do my due diligence and just spread the word of social distancing and how it makes an impact. But also just sharing the word that we're going to be in this for the long haul, and hopefully within the next couple of weeks we'll have some better projections and understanding of what exactly that means.
Thank you so much. Those were all the questions I got for you right now. We appreciate all your hard work.
Yeah, and
Yes,
thank
Kelly,
you all for everything you're doing.
Thank you so much, Kelly. We really appreciate it. At this time, I'd like to move on to discussing addition of licensed bed capacity under the Governor's Executive Order 52. Eric Bodine, have you joined us?
I am here.
Thank you, Eric. If you could please share a little information about the information that you provided to nursing homes yesterday, and we thank you for being on.
My pleasure. As you all are probably aware, the governor signed Executive Order 52, which allows the state health commissioner at his discretion to authorize general hospitals and nursing homes to increase their licensed bed capacity, notwithstanding the requirements of Certificate of Public Need. So in other words, without the need for going through the Certificate of Public Need process. And this is a great way for us to be able to stand up additional bed capacity as rapidly as possible. So yesterday we sent out a letter from the commissioner basically outlining the process that we're going to go through in evaluating those kinds of requests. And the letter is pretty self-explanatory, I think, and it, among other things, it lists a number of things that the commissioner is going to consider in making the determination to allow additional beds to be stood up. Their general criteria, and I don't expect that there's going to be, particularly as this thing gets worse, that there's going to be a whole lot of denials of it. But some of the things that we've been thinking about that aren't reflected in the letter is, so under what kind of circumstances would we say that this is probably not a good idea? And one of the discussions that we've had, and I had with a local health director, was about a hospital building that has, like so many of them do, they have a nursing home component in the building. And so the question is that the right place to be standing up additional acute care beds, hospital beds, in light of the proximity to the nursing home? And is that the best way to go about it? We don't have a particular, we were doing a hypothetical discussion because there was no specific request at that point, and still isn't. But we're trying to think through, some of the things that may indicate that the standing up of beds in a particular location is not the best idea. So to date, we have received, I think it's 8 separate requests or from separate hospitals. All of them are from hospitals to stand up about 222 beds. We're still in the process of evaluating those to send to the commissioner to make a determination on doing it. We're trying to do this as fast as we are, and as everybody keeps qualifying everybody's statements with, this is all new to all of us, so we're feeling our way through the process. But we recognize the need to be able to stand these beds up before they're needed, because it's going to take a little bit of time if people are going to start cohorting back into semi-private rooms that have been turned into private rooms. Do we need to go, or is that what the facility is proposing to do, to go back into that? That's going to take some time to do. If we're going to start converting those old patient rooms or resident rooms that are now used as offices, that's going to take a little bit of time to do. So that's where we are. It's important to note that the executive order is specific in it that any beds that are added under this COVID-19 emergency process are deemed to be licensed at the time that they're approved. So there's no additional licensing process to go through. With that being said, one of the concerns, the bigger concerns that we have, and it's one of the considerations that's mentioned in the commissioner's letter, is the life safety code status of the space that's going to be used for the additional capacity. And we think that that's a very important element, so that we're just not, I don't think we've gotten to the point yet where we're willy-nilly putting residents and patients in hallways and in broom closets yet. So we want to be sure that the space that they're going into is and remains a safe space for the type of patient or resident that's going into it. The other obvious concern that we have is I think that there's a fair amount of space available out there. What there's probably not a lot of is extra staff standing around. I think I've heard of some facilities that are starting to cross-train and repurpose some of their ambulatory staff over into the more acute care side in preparation for the surge, as well as a way of keeping those staff actively employed. That's kind of the brief of where we, and the other thing I think, we have gotten several inquiries about facilities with adjacent assisted living facilities. I think all the ones we've gotten so far are the assisted living facilities are within the nursing home, of using assisted living facility rooms for, not for additional capacity, but for a way of cohorting residents either away from a focus of COVID-19 positive residents, or as a way of cohorting the COVID-19 positive residents away from everybody else. So that we are looking at that as well, very much on a case-by-case basis. Kim Beasley, I think, is on the call as well, because we're all doing the social distancing thing and trying to continue the operations of the office from our individual homes. So I think she's on the call. So we're looking at, on a case-by-case basis, the use of expanding into the assisted living facilities. So far, not as an increase in capacity, but more of an opportunity to cohort away from infected patient residents.
Hi,
Are there
Eric.
any questions?
This is Kim. I'm on the call as well.
Okay, good.
Are there any questions in our chat box?
There are not at this time for Eric and Kim.
I want to thank you both for being on. We hope that you could stay on for the duration in case any additional issues come up. And thank you for all that you're doing for us.
Our pleasure. And feel free to give us a holler. Your questions are not confined to the time frame of this call. So if anything comes up, or if you have any concerns or issues, feel free to give us a holler.
We appreciate that. Thank you so much, Eric and Kim. Next slide. Okay. Want to move on to the topic of personal protective equipment. Next slide. I'm sorry that Mo had to, from Bechelon Retirement Community, had to leave our call, but we know this has been an ongoing issue for our communities, and want to know if there's any particular issues or things that you would like to discuss at this time. If you do, could you please unmute your line or put that in the chat box?
Dana, if I could just jump in
Yeah.
with the mask order. So all LeadingAge Virginia members got an email yesterday that Goodwin House is putting in a huge order for masks. I just got word that if you have not yet emailed me and them with your mask numbers, the cutoff is 12 noon today. That doesn't mean they won't do another order, but they're really concerned about somebody else grabbing all those masks and the distributors selling out. So if you have had a chance to look at that email, please send us your numbers, because they want to get that in at noon today.
Thank you, Melissa. Okay, I'm sure we can come back to this topic before the call is over.
And I just want to share, sorry, one more thing, Dana, from Mo. It's so important to keep adding the needs for PPE on the coalition websites, because if they can't get a stockpile, there's going to be a real challenge for everyone. So they have to have an accurate assessment to date, as accurate as you can, assessment to date of what your PPE needs are.
And I would like to add to that, a number of you have reached out to me on innovative ways for being able to share personal protective equipment. If you have supplies of that, if you could please let your healthcare coalitions know, and then they'll be able to disseminate that. Next slide. I think we've covered this issue. Christy Zeitz with Affordable Housing.
Good morning. Thank you, Dana, and hello, everyone. Just a couple quick updates on our end. You know, we continue to monitor and press HUD for guidance on a number of different things. As you all know, at this time, we're not allowed to lock down the building and completely cut off visitors and others from coming in. But we have implemented some strict screening of visitors. We've also communicated to residents and family members that really non-essential visitors are not really going to be allowed. They really have to make the case on why they're coming in if they're not a home health aide or a family member that's actually helping one of the residents. You know, we have a major project going on at one of our properties, which we've just, the board voted to put a halt to. So we are really doing what we can within the fair housing laws to protect the property and the people inside it, the staff and the residents. The other thing that we've stepped up on is really enforcement of our social distancing policies within the property. So, you know, as people are stuck in their apartments, they're getting a little restless and frustrated. And we had started to see people congregating a little bit more. Certainly we have small elevators and many of them were cramming into the elevators. And so we actually are doing a little bit more stepped up enforcement on in the lobby areas on each floor. And we have one of our cleaning ladies who is riding the elevator, monitoring how many people are getting on, and we're really enforcing those rules. I mean, it came to the point where if we're going to have these recommendations, and the residents aren't able to really follow them, you know, by their own self-discipline, that we really need to step up our efforts. And so as part of that, you know, management staff had sort of been locked away in their offices and not interacting with residents. All communication was really by phone or by email. And so we've actually got management with some PPEs out in the lobby area, out in the elevators, like I said, because if we are going to have these protocols in place, we want to make sure the residents understand that it's very important to stop the spread, and we're going to enforce that as much as possible. So that's what we're doing at the properties. We continue to have weekly communications via email with the residents. We also deliver a hard copy letter to the residents that don't have email, so that they can be reassured that the organization is on top of it and what we're doing, reminders of proper protocols. We also are communicating with them this week through a letter, all those reminders, as well as letting them know what we will do should a confirmed case be found on the property. We're trying to really tamp down the paranoia. If residents are watching the news 24/7, then you know that they're getting a little you know, overwhelmed by that. And so we want to really try to reassure them as to what we're doing. The other thing we're you know, continuing our efforts with volunteers who are willing to make grocery runs and pick up medicines, and how we're, you know, relaying those to the residents and dropping them at their doors and things like that. And so, you know, health and safety of our residents, making sure they have the food and the medicines that they need, as well as reassuring them that, you know, we're on top of these things, is our focus right now. We are starting to look at what next month looks like in terms of, you know, what activities can our residents do if we are still in the social distancing mode, and it sounds like it's going to be that way for a while. So we're going to be focusing a lot more efforts on what the new normal is, with people having to stay in their apartments, but how do we follow through on our programs and services. So if I have updates for the next time, I'll certainly let everybody know.
Christy, are your dining rooms closed? Are you doing room meal delivery for residents? How are you handling that?
At our properties, we do not have dining services. And so while we do have a number of food programs like the USDA Brown Bag and other donations of food that's being delivered by either management staff or volunteers, we do not have congregate dining at our properties.
Dana, can I jump in? This is Linda Couch with LeadingAge National.
Yes, thank you, Linda.
Sure. So just on the dining rooms, I know I've talked to affordable housing members who have dining rooms, dining programs, and it's really across the board. Some of them are trying to allow people to eat in the dining room, social distancing, so they're kind of near each other, but they're not at the same table. But most I've talked to have transitioned those into box lunches that residents can either take up or staff are bringing up to their apartments. And I just wanted to make sure people know that HUD issued last night a new frequently asked questions for multifamily owners. It is almost twice as long as the last FAQ. There's a lot of, a lot more helpful information in there, a lot less just telling you to go to the CDC website, which is good. There's pretty specific suggestions in there around what to do if there's a confirmed case in your community, and a lot of it is around having a good communications plan and what that plan could look like. There's information in there around specifically how to disinfect areas. And as we know from previous HUD guidance, HUD is allowing recertifications to be extended for a 90-day window, but now the new guidance talks about how HUD will be accepting electronic signatures, wet signatures, which is really great. And they're also allowing for electronic documentation from residents to show that, and for some more flexibility for interim recertifications, which is great. So definitely try to check that out. And then HUD, in the same communication, announced that there'll be a second HUD multifamily call for any stakeholder who wants to get on tomorrow afternoon at 2:30. And information about the FAQ and the call are on LeadingAge's COVID page for housing. That is the totality of what I wanted to share. Dana, thank you.
Thank you, Linda, so much. We really appreciate that update. Were there any other questions in the chat box?
Not at this time.
Okay, next slide. Allison Zuba, have you joined us?
Hi, good morning, everyone. It's great to be on this call and to hear all the strength through LeadingAge Virginia and National. And as a member here, we greatly appreciate that. From the adult day world, we have 79 licensed adult day centers in Virginia, the majority of which are now have voluntarily closed. And we have 4 different standard types here. We have for-profit, nonprofit, government-run, and university healthcare run. So with all those different models, as you guys know from your own business models, we're looking at how do we remain closed and still stay open to serve our folks once we can have everybody back in congregate settings. We are looking at, California has some cool models that they're experimenting with that we're hoping we can adapt to our state if it works through licensure, of course. And so that's been hitting really hard on the national level to try to figure out how we can accommodate that. For those of us who have agreements with the VA, where we're looking at can we do some telehealth to stay connected to our veterans and still also receive some payment to offset the zero balance that we're bringing in during all of this. And then also we have a call with DMAS tomorrow to see what that can do for us too. So we're all trying to think creatively outside the box. I know a lot of, quite a few centers anyway, have donated their medical supplies to areas around them. So once we reopen, we are wondering what we're going to need to make sure that we have in place. And because I think a couple of us have given away everything that we had trying to help out area centers. So it's a different time and it's a different landscape. So we are staying in communication as much as we can with each other while we're also looking at how do we handle our employees? Do we furlough? Do we lay off? Do we close? Do we stay open and use up all of our PTO? The business model opportunities it's a big learning curve. So any guidance anybody has on anything we'll take. So that's all I have, Dana.
Thanks so much, Allison. I wanted to give the Department of Social Services an opportunity, if Cindy Carneal was on, if you had anything you would like to share at this time. Okay.
Hi, Dana. It's Cindy. And
hey, Cindy.
Hey, how are you? We are trying very hard to get some FAQ information out, not only to the adult daycare centers that will hopefully help with some of their decisions, as well as any other strategies that we have proposed, and we're just waiting to see if they're approved. So I know it's a waiting process for everybody, and I do apologize for that, but it's got a process that everything has to go through. I can't just tell you what I would like to see, and I apologize for that.
Well, we'd love to be able to tell you what we'd like to see too and have that happen, but you know.
I know.
but we'll make it
you.
work.
Well, thank you, Cindy. Thank you so much for all you're doing for Adult Day and for taking time to be on our call today. And thank you, Allison.
Oh, thank you.
Before we move on to the LeadingAge national updates, I thought that LeadingAge might also incorporate this information. A question just came in to discuss how independent livings are handling new admissions. So I wondered if LeadingAge might also have some information to share with us on that. So with that said, I will hand it over to Dee Procon. Thank you so much for being on.
Good morning, everybody. This is Dee, and I know also Janine and Linda from our national team are here. And so I'll just speak to the independent living piece, and then I'm going to turn it over to Janine for nursing homes and national updates, and of course Linda too for anything else on affordable housing. And yes, that question has come up and has been shared from a few states. Specific to what do we do about residents moving into independent living and what are different providers doing. So there are a few approaches to this. Some providers have just stopped all incoming moves into independent living based on the current situation. Some are exploring testing and asking those residents to self-quarantine either in their own home if they have not yet sold and moved out, or once they arrive to campus. One of the things we've emphasized is to make sure you check with your general counsel, review it with your risk management folks, and of course, especially if you're a fee for service, look into the Fair Housing Act to make sure that you're not running into any static there. But of course, first and foremost is the safety of all residents and staff and community members, and try to prevent the spread of the COVID-19. So that's one piece. A couple other quick pieces. There's of course so much going on in so many areas. We have had a lot of questions about in independent living, you know, when independent living residents are exiting campus and then coming back onto campus, and what to do in terms of potential exposure. So we're putting together some resources on that, but quite briefly, things to consider are, you know, if independent living residents are leaving campus and returning, are you screening, or do you have a screening tool in place? Some are doing this when people return to campus related to travel as well as symptomology. You're going to have to, of course, think about how to control your access points or how to gather that information. Some communities have gatehouses, so it's fairly straightforward. Others don't. So you'll need to take a look at your access points, and many are considering that. And then depending on what you find out, you know, from those screening tools and where people are going to and from, you know, some communities are putting in place a self-quarantine requirement. So if the resident returns to campus and they meet certain criteria on the screening tools, they have to self-quarantine at home. Others have even said they have to self-quarantine off campus, and especially in the cases of international travel or travel to states with confirmed cases, which now there are in all 50 states. The other thing that we've had a lot of dialogue and questions about are deliveries and service modification. I'm going to stick specifically to questions we've had about disinfecting deliveries. You know, folks have had concerns about COVID-19 and its viability or how long it lives on surfaces. Today we'll be posting an article that reviews at least the current research, caveat being that of course it's still emerging research as it's a brand new disease and there's not a lot of study out there. We have gone through what is available at present and can share, for example, with cardboard. Initially it looks like it can live on cardboard for up to 24 hours. So thoughts around that initially are, either sequestering those deliveries for more than a day, or, doing some sort of a wipe down or disinfecting procedure. There's the other information that you'll be able to see once that article is posted, because I know we're short on time, but it is something that is coming available today. And last but not least, just from a templates perspective, we have also had questions about, templates for if we have a positive case, especially in independent living, but you can apply it across the campus, as well as if we're doing testing and how to communicate that. So we put together a couple templates on that are on the website now. So that's just my brief piece on the independent living side of things. And now I'll turn it over to Janine for nursing home and other general national updates.
Wait, before you turn it over, can I just ask a question that came in? What are you hearing that folks are doing about staff who use public transportation to get to work?
That's a great question. I actually have not myself had that question come up yet, so I will start looking into that, and I'll see if my colleagues on the call have had any questions along those lines.
So this is Janine. Yeah, we have not really had a focus on the staff who use public transportation. I know that here in DC that some of the metro stations are being shut down, but as Dee said, we'll look into see what we can come forward with, some either helps or any other resources and so forth.
Thank you, Janine. Did you have any nursing home updates for us?
I do. I just want to make sure that all of our nursing home organizations have reviewed the memo that came out on Monday, but it is dated March 20th. It's the memo that is the subject line of prioritization of survey activities, knowing that for the next 3 weeks, which started on March 20th, that the survey teams, both state and federal, will be only using the types of surveys that are prioritized and conducted by this hierarchy, which is any complaints or facility reported incidents that fall under or triage at the immediate jeopardy level. During that survey, please note that the survey team will also do a streamlined infection control review using the tool that is attached to this memo. I'll talk about that in 1 second. There are also going to be targeted infection control surveys. These that can be done either by federal or state surveyors, and they are through collaboration with the CDC and the HHS Assistant Secretary for Preparedness and Response. They are using a streamlined review checklist to minimize the impact in the organization as the surveyors move around to protect the health and safety of the residents. And then the other part of this memo goes into self-assessments. So using the summary of the focus survey, so CMS actually gave the tool that the survey teams will be using if they're doing a review or a targeted survey on infection control, going through what they will be doing off-site, what they'll be doing on-site, and then actually putting in a facility self-assessment. What's important for members to know is that that self-assessment is voluntary, but CMS is recommending that your organization do the self-assessment, have that available, because if you are a targeted nursing home for infection control surveys, you're going to be asked to see that self-assessment. You then do have the option of submitting that self-assessment to your state Department of Health. But I think that it's a great way to see, have you met all of the requirements that would be that a survey team would be surveying you on for a targeted infection control survey. We will be posting later today a checklist to help administrators and the executive teams for nursing and infection control nurses, a little bit more in depth of just kind of going down and making sure you have this. So a tool will be posted on our website. Talking about our website, the COVID-19 is linked in there with provider specific updates. So Linda, I referenced it before. What I want to say that just came out this morning at 10:30 is there as a CMS nursing home call at 4:30 today. And that will also include CMS updates as well as I think best practices throughout the country. I sent that link I think for both Dana and Paula, and I know that Melissa has it also. So it can be sent out so you can sign on to that call today. We're hoping for no technical issues, excuse me. And then I think the last piece that I want to mention is that there is a lot of things that are moving fast and furious for nursing homes, but please know that we're trying to do analysis on whether a memo comes out or a different change, and we do link those all to the COVID-19 page. But feel free to ask any questions. You can email myself, you can email Jody, you can put them in the COVID-19 member community or the generic COVID-19 email address that we have that's also listed on the website. So that's everything I have. Thanks.
Thank you, Janine. We appreciate that update. Thank you so much. Next slide. Are there any agency updates from the Board of Long-Term Care Administrators? Office of Licensure and Certification.
Dana, this is Kim Beasley. I think that the previous person who just spoke did a great job at describing the new CMS guidance that we just received, part on Monday and part yesterday. There is a slight change in their stance on survey activities prior to this week. They changed their guidance on the fact that they are expecting us to be out providing more surveillance. Of course, we've always had the guidance there to conduct the immediate jeopardy complaint investigations, but the next step down the tier of survey priorities are these focused infection control surveys. And so, we will be out and about some. There's a lot of the process that can be done remotely, and we're going to take as much advantage of that as we can. So we're working through this on how facilities will be selected or identified to participate in these focused surveys. We do know that some of the information is going to come from CDC, but we're supposed to work with our local health departments in identifying facilities that are of concern or potential outbreaks, so forth. So we're just getting started with this today, trying to get it, our plan up and going, and we're waiting on additional information from CMS in addition to what they've already sent out. So stay tuned. Again, this is different from what we had last week. So this is what's in place now for the next, effective on March 20th through the next 3 weeks. So.
Thank you, Kim. Thank you so much for that update and for being on. Next slide. We'd like to take it back to revisit a couple questions with John Burns. Melissa, over to you.
Thanks, John. Just 3 quick questions. First, I think you mentioned this. How long did it take for the test results to come back? Was it 24 hours?
So there's a couple of answers to that. When you have a positive, a hospital case is going to get tested very quickly. And so when we had our resident go to VCU Health, it was early in this. They really didn't have anyone in there. He was, I think, the first inpatient. We got that result back in less than 24 hours. It was, it was right at about 24 hours that we got that result back. And then when the state came in here on Monday morning, the epidemiologists have a process where they go through and they trace who's all been exposed and who in our nursing home was having cough, shortness of breath, and fever. We did have some suspected flu. So those tests were done by the state lab, and there were 4 or 5 that were done. We got those results back in about 30 hours, probably 36 hours, a day and a half-ish. And those were only people with symptoms. We had, in the theater, we had 290 people exposed, and in independent living prior to moving to the healthcare, we had another subset, and then we had about 35 staff who were exposed. They were told they weren't going to be tested unless they had symptoms, and then they had to go to one of the public testing sites. We still haven't gotten those results back. The only results back we've gotten have been those that were done in-house or done at the hospital. Thankfully, every test we've gotten back has been negative, and we've not had any more cases, but we've probably got 8 or 10 cases, exposures that are still pending, but no one has symptoms.
Yeah, I just found out from another member that it was 6 days for a test to come back for one of their residents.
Dr. Avila at Public Health yesterday told us to expect 7 to 9 business days.
Wow. Okay. So another follow-up question, John, I'm sorry, I'm scrolling. What did you and your team do to reassure folks and keep paranoia to a minimum?
So at the beginning, from the very beginning, we asked Dr. Avila from Public Health to stand with us at 9 o'clock that very first morning and say whatever he needed to say to help calm. He is a fabulous partner. He's a wonderful physician, and he has a very calming demeanor. And he said, "You all are safe. Westminster Canterbury's done it right. Follow their lead, and do what management says, and you'll be fine." Then from there, we've done twice a day. We've been on TV at 10 o'clock and 3 o'clock, Monday through Friday, and once on Saturday. We've been in front of them, just keeping them up to speed, sharing everything, letting them know how the patient in the hospital's doing, and stressing to them that they're safe if they stay in their home and they socially distance. And the response has been good. Now, we get a week and a half into this, our residents are getting a little antsy and they want to get out. We're currently having our physician resident community, and it's about 25 physicians, are co-drafting a letter requesting that the residents continue to follow the lead and they'll be safe. And so that's the next phase, is now people want to get out. They want to get back to life, and we're a long ways away from that.
One last question for you, John. It's really a question for everybody, but I know we're really out of time. Since you've been so prepared, have you put together any alternative staffing scenarios? Should something happen that staff get COVID-19 and have to be out?
Sure. So we have probably somewhere between 25 and 30% of our staff that are not here on every day because of either exposure, a loved one who's exposed, or some other sort of dynamic. So we're running really short. From the very beginning, we reached out to our country clubs here in town because they've hired up for the spring and they're having to pay people to stay home. And so we've got a contract in development right now to rent staff from one of the country clubs here in town to help with the dining needs. Because as you all know this, if you're a CCRC, right, delivering meals to 870 residents, 3 meals a day, is a whole new business model for us that we've never done before. And we are running very thin at our gates and temperature checking tents, and people are getting tired. So we're probably going to have that implemented in the next few days. And then our friends within the LeadingAge community have shared resources for agencies that have staff. We've not had to deploy any of those contract staff to this point, but we are ready to if we lose. Let me say it differently. If God forbid we have another case in our nursing home and we have to lose another nursing team for 14 days like we did the first time around. And we're lucky we do 14-day, we do 12-hour shifts. So during that resident stay in our nursing home, we only lost 1 day shift and 1 night shift because the team didn't change. But it's still, it's a huge hit. When you have multiple exposures, you lose a lot of staff for a long time. If that were to happen again, we'd have to bring in help.
Thank you so much, John. Thank you.
Can I just speak to the PPE for 1 second?
Yeah.
I know that everybody's struggling to find masks and gloves, and we've been in the middle of this now for 10 days. And our initial stress was we need masks, we need N95s, we need surgical masks. Those channels are are freer than we thought they would be. And in our case, we're using a lot of them. We're okay. We have enough for now. Where we're really starting to get stressed is we're out of sanitizer, we're out of sanitizing wipes, we're out of those things because there really isn't anything in the supply chain, and there isn't really any government help or agency help to get more. So to the degree you have that stuff, I would suggest you hoard it and don't let people waste it, because if you have an event, God forbid, you're going to get masks, you're going to get stuff. We have plenty right now for ourselves, and if we have a case in our member group, we're going to be able to help. But we have plenty of N95s, and we have a few thousand surgical masks, and we have more on the way. So that's not really where the tension is. It has more to do with keeping this place disinfected and keeping staff clean. So take that for what it is. It's just advice from the front line that when you actually have a case, the masks are still very relevant, but that chain opens up a lot faster than some of the other ones which you're not prepared for. I'll stop.
Thank you so much, John. Dana?
Thank you, John. Next slide. The slides coming up are having to do with all of our upcoming calls. Our next weekly member call will be on April 1st. Next slide. We have a member human resources call scheduled for Thursday, March 26th. Next slide. The DMAS Adult Day call, Thursday, March 26th. A webinar coming up about what everyone needs to know about the Family First Coronavirus Response Act. Next slide. Another complimentary webinar, Crisis Communications Managing the Media. And information about philanthropy and development call-in for March 31st. And we are here to help you.
We should mention that all of that information will be in our daily update today.
Yes.
So, because you went through that really fast. So people, so don't worry about jotting all that down. You'll get registration information when the daily update goes out around 3 o'clock this afternoon.
Yeah, thank you, Melissa, for that. We're here to help and want to thank you all so much for being on and continue to let us know what you need. Thank you all.